Parotidectomy by Belinda Thomas. Parotidectomy is removal of partial or the entire parotid gland. It is performed to treat the diseased portion that may be caused by a benign or malignant tumor or cancerous lymph nodes. Other symptoms for parotidectomy are chronic inflammation, infection, and parotid gland stones. Disease more than likely occurs in the superficial lobe and rarely involves the deep lobe of the parotid. There are three types of parotidectomy. Superficial parotidectomy is partial removal of the gland above the facial nerve. Total parotidectomy is both the superficial and deep lobes of the parotid gland are removed. Radical parotidectomy is removal of the facial nerve and sometimes the temporal bone and tissues over the parotid gland. After the parotidectomy, a frequent complication is Frey syndrome, sweating and flushing of the facial skin in the area of the parotid gland, which occurs during meals. The salivary glands produce saliva, which irrigates the oral cavity and contains enzymes for breaking down simple carbohydrates. Buffers in saliva reduce acidity in the mouth and protect against pathogenic bacteria and demineralization of the teeth. The parotid glands secrete saliva to keep the mouth moist and aid in chewing and swallowing the food. The parotid glands are the largest of the salivary glands. They are located over the mandible or just below and in front of the ears and extends anteriorly to the masseter muscle. The tail of the parotid gland extends below the mandible into the upper neck. The parotid duct drains into the mouth and cheek just opposite of the upper second molar. The submandibular gland is the second largest salivary gland. Its C-shape wraps around the lower border of the mandible and emerges from the deep interior portion of the gland and drains into the anterior floor of the mouth. The sublingual glands are the smallest and lie in the floor of the mouth just beneath the mucosa and empties into the oral cavity through multiple small ducts. The sternocleidomastoid muscle, or the SEM, separates the neck into two large triangles known as the anterior and posterior triangles. The SEM is attached at the superior end to the mastoid process below the ear and inferiorly to the sternum and the clavicle. Below the SEM is the carotid sheath, which contains the carotid artery and its bifurcation, the internal jugular vein, and the vagus nerve. The digastric muscle is comprised of two muscular bellies which are connected by an intermediate tendon which is attached to the hyoid bone. The digastric muscle depresses the mandible and elevates the hyoid bone. A fine needle aspiration is taken as a biopsy prior to surgery. Ultrasonography, CT scan, MRI, sonogram, radionuclide imaging. Routine tests are advised before surgery, which include blood tests, kidney function tests, urinalysis, and ECG tests. General anesthesia via endotracheal intubation is employed. Neuromuscular blocking agents are not used to allow for stimulation of the facial nerve for identification. The patient is placed in a supine position with the head turned to the side on a padded foam or gel donut. The dependent ear is well padded to prevent pressure injury. The arm on the opposite side may be padded and tucked in at the patient's side. The contralateral arm may be extended on a padded arm board. Pillow may be placed under the knee to prevent lower back strain. All bony regions are well padded to prevent skin damage, neurovascular pressure, or trauma. Prep solution is verified with a surgeon. Begin prep on the affected cheek. Extend the prep from the hairline to the entire side of the face, well beyond the midline, including the ear. Place a lap sponge at the side of the neck to prevent pooling. Small cotton ball is placed in the ear to prevent pooling inside the ear. Extra care is taken not to get prep solution in the eyes. The modified Blair incision is made in the preauricular region and continued inferiorly around the earlobe anteriorly to the parallel the angle of the jaw. Draping. Adhesive back sheet is placed across the forehead and 4 towels are draped around the head and the neck. A plastic adhesive drape may be used. The body is covered with an adhesive back split or U-drape, draped around the neck to secure the perimeter of the operative area. Medication: lidocaine with epinephrine, gel foam, thrombin, silk ties, sutures per preference of surgeon, marking pen, base and blades 15 and 10, suction tubing, electrosurgical pen with cord, holder and scraper, dissectors, umbilical tape, vessel loops, bulb syringe, 2 pillows, paddings, nerve stimulator, step stand, fiber optic headlight, just to name a few. Basic and minor procedure tray, thyroid tray, tracheostomy tray, right angle clamps, finely pointed, small Yankauer suction, nerve hook, small and medium hemoclips, and skin hooks, sterile wires with needle electrodes. Jackson-Pratt drainage may be placed in the wound before closure and after radical procedures. Fluffs and burn netting around neck can be used. A specimen will be sent to pathology. It is a Class 1 clean wound. The modified Blair incision is made just above the level of the zygomatic arch and continues inferiorly around the earlobe, anteriorly parallel to the angle of the jaw. With more experienced surgeons, microparotidectomy incisions are used. When the sharp dissection is performed, the bipolar ESU is used to coagulate the bleeders. The skin flap is sutured and retracted from the field, or a flap is elevated to have better access to the parotid gland. Careful exposure of the greater articular and facial nerves are necessary at this point. A nerve stimulator is used to test and confirm the integrity of the facial nerve branches. If a major nerve branch courses through the tumor, it is sacrificed and a nerve graft is substituted. The nerve graft may be obtained from the greater articular nerve or the superficial branches of the cervical plexus. To compensate for the removal of the tumor, the sternocleidomastoid muscle or a graft can be used to reconstruct the site depending on the patient's surgery. By adding a layer of tissue to the site, this will lessen the risk of Frey syndrome. A picture of the patient is used to aid in comparing the facial sides. For closure of deep layers, a 3-0 absorbable suture is used and a 2-0 vicryl for the skin.